Super. Well, welcome everybody. I know it's been a long day and you've had plenty of talks and conversations. And so I'm going to add hopefully a little spice to the afternoon and we'll take it from there. So what I'm going to talk a little bit about is how we look at epilepsy. Dr. Kirsch's presentation was a wonderful cue in to me, which is, and what is the most important thing? And most important thing for us is to know where the seizures are coming from. And if there's a tool like MEG to be able to localize those seizures, then it allows us to potentially come up with a hypothesis, one in which that we can hopefully act on, and then look at ways to treat these children. So in essence, I just want to disclose that I do work as a consultant at times for Medtronic, mostly in their innovation and areas. And so really looking is how can we push our technologies in a positive way. I won't refer to them by name, but if you see anything, please feel free to bring it up. But anyway, let me just give you an overview. Again, the surgical treatment of epilepsy has been around a long, long time. In fact, it dates to the end of the 19th century where early surgeons, they weren't even neurosurgeons at the time, began developing ideas and ways to treat epilepsy. And so it's been around a long, long time. But for the most part, it's been really a treatment for adults. And there have been good to excellent outcomes in the adult populations. But interestingly enough, there's been a recalcitrance or a resistance to treating children, despite the fact that epilepsy is the most common neurological disorder of childhood, with an incidence of about 2%. And so the reality is that we oftentimes, many patients will go on and have seizures throughout their childhood into young adulthood to adulthood, and so have seizures for 10, 20, 30 years before they come for potentially treatment. The fact of the matter is that surgery is the only treatment of epilepsy that is curative, but not all patients can be cured of their epilepsy. But as a result, surgery should and has been considered an alternative once medications have failed, or alternative treatments, or diet, or those kinds of things. And so surgery is part of the armamentarium. What we're trying to do is to stop the seizures. So what I hope you'll take away today is that indeed the best outcomes and those that we can possibly cure come with the most accurate localization of where the seizures are coming from and where they're going. That's what's called a seizure network. And you've probably heard that today, which is oftentimes there's a focus or an area where the seizures are coming from, and then they spread throughout the brain, and that's the network. The newest innovations have been those that have allowed us to improve our diagnostic accuracy. And so by being able to more accurately define where the seizures are coming from, we can then come up with newer and more minimally invasive surgical innovations in order to try to lessen the potential risk of complications and problems with surgical intervention. Additionally, with better understanding of these seizure networks, and even those that we can't cure, we can get great outcomes in the areas of neuromodulation. And it was alluded to by the use of vagal nerve stimulation, but there have been a number of other neuromodulatory devices that have come out over the last few years that didn't exist. And as a result, now with their introduction, has opened up an avenue for more and more patients to potentially benefit. So I'm just going to show you a kind of a quick case presentation that I'll use as a wrap up at the end. But you can imagine as you listen to my talk is what might we be thinking about, and what might the innovations in technology that we would apply to this problem. Well, I met this young girl. She was 3 months old, and she was diagnosed at the time with tuberous sclerosis. Unfortunately, she was noted to have seizures starting at 6 weeks of age, but at a minimum, in retrospect, it was likely that they started at birth and may have even been in utero. She was clearly having catastrophic epilepsy, so she was having 50 to 60 seizures per day. Medications would reduce that initially to about 3 to 5, but then as the medications wore off, those seizures would rapidly escalate back to 50 to 60 per day. She was tried on multiple medications. As you can imagine, at 3 months of age, the medications would work and then not work, and then as a result, we really were in a significant problem. But the family had been told to come back at 18 months of age when surgery might be considered. And so what I'm going to talk a little bit about today is that we shouldn't wait, number one. Number two, the earlier the better. And that really does work in favor of having better outcomes. Here is the, just to let you know that her EEG localized to the left frontal region. Here's her MRI, and you can see while she had multiple tubers in different parts of the brain, you can see this very significant tuber here in the left frontal lobe for this particular child. And so we've got anatomical localization and we've got functional localization, and I'll let you imagine kind of where we went from there. Now, having said that, I'm going to move on to a little bit of what you've probably heard a bit today, which is the reality is that epilepsy can occur and develop throughout one's lifetime. We see an initial spike early in life. We see less frequency and later in life, and then as we get into the older age groups, we start to see another incline in the incidence of seizures and epilepsy. With regards to refractory epilepsy, we know that about half of patients who develop epilepsy will be responsive and become seizure-free with one drug, the first drug. Then we know that about 11% will become seizure-free if they have a second drug, either in combination or in alone, in isolation. And then that percentage goes down to about 4% once that person has been on 3 or more drugs. And so the reality is when we start to look at the total number here, we see that about a third of patients will be medically refractory despite the use of 3 or more drugs. And so if we think about this with regards to the US population, we know that the prevalence in the United States is about 3 million people living with epilepsy. We know that if we use that statistic, that about a third of patients will not be responsive to drugs. That shows that there's about 1 million people out there in the United States who have refractory epilepsy. We know that there's about 150,000 new cases per year that are diagnosed with, and again, using that statistics, that we know that they will go on to become, about a third of those will become refractory epilepsy. And yet, if we look at the total number of seizure surgeries, there's about 3,000 per year that are done in order to try to cure the epilepsy, and about 4,000 neuromodulation devices, which are there to palliate the seizures. And so you can imagine that we're falling woefully behind when it comes to those patients that would potentially benefit from a surgical intervention. And as I alluded to in the introduction, sometimes the average duration of refractory epilepsy for patients is about 20 years before they actually are evaluated and come to a surgical treatment. And so I do believe that this is a very underserved population and one that we need to get better at addressing it. As you can imagine, part of that is concern or fear about surgery, but the other is in the past has been our ability to localize where the seizures are coming from and really better understand, each individual's epilepsy. No longer do we totally group them together as I do here. Overall in adults, I'm just going to move this over. Overall in adults, we see frequently complex partial seizures of temporal lobe origin. It's usually a single small focus. And this is really a group that can be cured because this is a relatively localized lesion that can be removed and potentially cured of their epilepsy. Children, on the other hand, are a bit more complex. We're seeing children who have developmental problems, who have brains that have not formed well. Oftentimes, they can have very diffuse or generalized seizure types. They're often extratemporal and cortical, and they could be in locations near areas of motor or language function. As I mentioned, not often a small focus, sometimes very large. They can have numerous seizures per day, and again, it becomes your definition of what's intractable. And as well, because of the problem with the seizures and problem with multiple medications, often toxic levels in order to get control, these children often grow up with cognitive and behavioral developmental issues. And as I mentioned, the issue of intractability has different definitions for different people. Some people feel that one seizure a year is a significant seizure burden. Others, it's one seizure a day. Again, it's relative to what is the impact of those seizures on one's quality of life. If someone was working and driving and now all of a sudden has one seizure, now all of a sudden can't drive or can't do their particular career, well, then that seizure burden is potentially intractable because it's impacting on vocation and quality of life. Children, they're not driving yet, but they can have cognitive and behavioral developmental issues. Again, one needs to weigh what is intractable in each of these populations. So ultimately, the goals of epilepsy intervention, whether it's medications or diet or alternative treatments, is to stop the seizures. By stopping the seizures, we hope to prevent further brain injury or interference of normal brain function, because a seizure is an abnormal functional aspect of the brain. And in children, we hope that by early and complete cessation of the seizures, we can allow for more normal development. But that's also true in adults. I'd like to think that I still have a developing brain, even with the gray hair. I can still learn a new language and learn to hopefully get better at golf and things like that. And so we have to recognize that we still have the potential for plasticity, and we still have the potential for neural development even as an adult. And we know that ongoing seizures will lead to cognitive decline, particularly if they're having a significant impact on one's daily life. So what then are the goals of surgical intervention? It's the exact same things. It's to stop the intractable seizures. And again, prevent further brain injury and allow for the normal brain to function, as well as to allow for more normal neural development. And so what we say is that epilepsy surgery is the best option for the right patients, but the right patients really come down to us being able to understand the seizure syndrome. We know that for receptive patients, if they have a small focus, it's an area that's not eloquent, so not an area of motor or language functions. It's an area safe to remove. And in particular, if they've already failed medical management, that these would be the most qualified candidates to hopefully achieve a cure. But the reality is that cure cannot be for everybody. And so we need to look at the complete patient and understand what's going on specifically, so that indeed we can provide a good treatment plan. And whether, again, it includes medicine, diet, alternative treatments, and or surgery, it's important to take all of those different things into consideration. So we know with regards to our surgical decision making is that our best outcomes are dependent on us understanding the seizure type, the ability to lateralize and eventually localize the seizures, indeed, and identify the pathologic substrate. So is it a cortical dysplasia? Is it a tumor? Is it a vascular malformation, a previous stroke? Those kinds of things. All of those have an impact on us understanding what the seizure network arises from. And so our ability to visualize the anatomy, so our improvements, and I'll talk a little bit about these in a bit, but our ability to see where abnormality lies, again, things that we might not be able to have seen, even just a few years ago, because our MRI, our imaging has gotten so much better. To understand the abnormal functions. So as Dr. Kirsch was alluding to, being able to observe and see where there's abnormal electrical activity. Those are the abnormal functions. And if we can marry that anatomy and that function together, then that gives me as the surgeon a roadmap to potentially treat or cure someone's epilepsy. And so I'm going to talk today, sort of moving on, is where have our technologies taken us over the last few years in order for us to better localize where the seizures are coming from and come up with better hypotheses as to which way the seizure network is transferring itself. And so part of that you may have heard already is this concept of source localization. So our ability to understand where abnormal electrical activity is initiating and then how it's spreading. Improved anatomic imaging through the use of cortical thickness maps or diffusion tensor imaging, which looks at the tracts of the brain and to see how they may be normal or abnormal or how they are relative to where we think the seizure focus is coming from. As I mentioned, epilepsy is a functional disease, so we want to see where there's abnormal function within the brain. And so you've heard of SPECT scans, PET scans, functional MRI. And again, one of the areas that we're very high on is this resting state functional MRI, which again allows us to look at seizure networks and abnormal networks within the brain. And then you've already heard from Dr. Kirsch relative to MEG, and this is an absolutely important advancement in our understanding of what's going on in the types of functional abnormalities in the brain. And then there's different ways of mapping the brain, and probably not from me per se, but you'll hear from potentially others looking at ways to map out where normal functions are versus abnormal functions and whether we can non-invasively modulate those abnormal areas. So standardly, when one goes into an epilepsy monitoring unit or goes in for an epilepsy evaluation, I heard one of the questions on the previous speaker. So what we're trying to do is we're trying to get the history and semiology. So what do the seizures do? How do they occur? Because those give us clues as to where they may be arising from. Then there's the EEG, which gives us the brain waves and to look for abnormal electrical activity. But we often just take not just the short-term EEG, but then go to an epilepsy monitoring unit with the goal to record and visualize the seizure onset electrically, how it then spreads through the body, and how it spreads through the brain. And then that gives us a very good idea of where the seizures might be coming from. Imaging has become even that much more important because with our new sequences, we can see better anatomy, and with our new technologies, we can see where there's abnormal function. A neuropsychological assessment is important because it, again, shows where development has already started to be impacted. The cognition, one's language ability, memory, reaction time, those kinds of things give us a hint to areas that may not be functioning well. And then there's other types of functional tests, but I'm just going to allude to those. Those have been around a long time and are used less so now that we've got a lot of these new non-invasive technologies. So going on to the imaging, there's two types of imaging. There's anatomic imaging, which most often is using MRI scanners. And then there's functional imaging. As I mentioned earlier, this is looking at how the brain is functioning in real time. So PET, we're looking at glucose metabolism, as well as the potential for tumors. SPECT scan, which is looking specifically at how the brain's blood flow looks at a particular time. And then there's MR spectroscopy, where we can start to look at a biochemical profile of different parts of the brain. And then this gives us an overview or a map of kind of where things may not be functioning appropriately. And then again, I won't get into MEG, but I do think that it's an important electrophysiologic image that allows us to combine all of these different targets together. But the reality is that no one imaging modality can answer everything for us. And so that's the reason that a multimodal approach, so using a lot of these different components together, allows us to bring together this information and be able to then start to target where abnormalities may arise. So with regards to neuroimaging, again, you've seen MRI scans. This looks like a pretty normal scan when one looks at this here, but when we do a different sequence, now we can start to tease out an area of cortical dysplasia. And here we can see it in a different angle to be able to see, ooh, this is a really targeted area of abnormality. Now, what do we need to know with regards to other parts of the brain? Well, we can do what's called an anatomical or cortical thickness map. So this here, this is a patient that had electrodes placed on the brain. We were mapping out where the seizures were coming from, but we were also starting to look at where there was abnormal areas of the brain. So here's the motor cortex here in purple, but here are areas where there was some extra thickness to the cortex. And again, this is comparison to normative studies and thousands of normal MRIs. And so this looks at where does this thickness, is it outside of the 50% level? Is it 100%? Is it beyond a certain number of standard deviations? And so in this particular patient, we were looking for whether there was indeed differences in the anatomy, and these were not picked up on an MRI. This is in really taking an anatomic analysis of the images and being able to show, was this thickness outside of the norm? And then we can marry this onto areas where we've got what's called high frequency oscillations. So we can start to look at function, and now we start to look at abnormal function and start to map those directly onto the areas of the abnormal cortex. So not only did we find in this particular patient abnormal cortex in this area, but we were also starting to find high frequency oscillations just posterior to it, more so in this area, even though this was an area of anatomic abnormality. So interesting, again, we're looking for concordance of that information. With regards to functional imaging, I've already kind of given you these lists, and I'll just move on. So here's a PET scan. So this measures glucose metabolism within the brain, and one can appreciate the difference in the left temporal lobe compared to the right, where we see a drop off in the glucose metabolism in this area. We can also take the PET scan and align it on top of an MRI. So here was a patient with a normal MRI, but yet we were able to take the PET scan, show an area of low glucose metabolism, and this was an area that also mapped out to where their EEG was. So again, creating multiple layers of information to be able to give us a better idea of what and where the seizures might be arising. With regards to SPECT, this looks at cerebral blood flow. So interictal, so in between seizures, SPECT, really not, it's a little bit difficult maybe to understand if there's really a difference between the two sides. Here's an ictal SPECT. So this is an injection of the radionuclide material right at the time that they're having a seizure. A bit better sensitivity and specificity. And you can see on here a pretty kind of vague idea of where the seizures might be coming from. We can then do what's called a subtraction study, which is a SysCom. And if we take the abnormal scan from the interictal scan and then subtract those images, now all of a sudden we start to see a really nice map of where the seizures might be coming from with using the SPECT scan to look at cerebral blood flow. And then we can again marry this type of thing onto a MRI scan, and now we have a very nice targeted area for the neurosurgeon to look at this and say, okay, what would be a way for me to target this area, and what might be a different modality that I might be able to treat in this particular situation. And so, having said that, I think you're getting an idea of how we start to think about ways to better understand what's going on and how we might be able to treat it. One of the other areas that we're very excited about is functional MRI. It was originally developed as what's called task-based fMRI, and that requires you to lay in an MRI scanner and to do specific tasks. So if we want to measure your language, we would have you speaking in the MRI scanner. If we wanted to look where your motor areas are, we might do what's called finger tapping, so do repetitive motions. And what this does is when we use a particular area of our brain, whether it's language or motor or something like that, what we're doing is increasing the metabolism, the glucose metabolism in that area. As a result, we also then increase the blood flow because the brain needs more oxygen and glucose in that area if it's going to be functioning. So as a result, we can then start to map out where there's increased blood flow within a particular part of the brain. The reality is that it's very difficult to do that particular type of MRI, a task-based functional MRI in children, because it's, number one, hard to get a 5-year-old to lay still in an MRI scanner for a couple hours and then to follow tasks. And as a result, many children were excluded from being able to, utilize this particular modality. And that's the reason that we've now seen the resurgence of resting state functional MRI. So this is an ability to take a look at all the normal MRIs, the normal function, the normal blood flow in the brain, and then look for networks that are outside of that area of norm. So we know that seizure networks use sometimes more metabolism or less metabolism. So we know that there's some differences in those areas. You saw that on the PET scan and on the SPECT scan. And so what we're looking for are differences in what's called the BOLD sequence, which is really a measure of cerebral blood flow in particular areas. And so when we have areas of decreased blood flow or increased blood flow, those are outside of the norm. We can then start to figure out what might be some of the areas that might be useful to take a look at. Here's just some normal areas that we would expect normal networks to exist in the brain. Here's the normal language networks in somebody who's left language dominant, and we can see what those normal networks are. And so when we start to think about these things, we can now start to look for where there's abnormal. And here we can see this was an abnormal network within the left temporal lobe that indicated an area of likely seizure network. Similarly, we have a patient with a tumor here that has seizures, but we don't know whether the seizures are coming from in front, the side, or behind. And so in order for us to not only treat this patient's tumor, but hopefully cure their epilepsy, it would be important for us to know where their seizures are coming from. And so you can see on the MRI scan where there was the seizure network in this particular patient relative to this child's brain tumor. And so we could do a strategy to go in and remove the tumor, but also help to try to cure their epilepsy as well. Here was an interesting case. This was a patient with a lesion back in the parietal lobe, so far posterior, but it's interesting, the EEG and the semiology seem to measure into the left frontal lobe. So not concordant data. The data is not matching up in this particular case. Well, here was the MEG of this particular patient, and you can see very localized to the area of abnormality that we saw in the MRI and not frontal in nature. As a result, in this particular case, we were able to do a strategy where we identified better where the seizures were coming from using depth electrodes. And in those instances, we were able to cure his seizures. And again, it was localizing to that posterior lesional area. So again, in some patients, when we really can't define exactly where the seizures are coming from, either right to left or sufficient localization because of its location potentially near motor areas or language areas, that there's a non-concordance of the data. Those would be reasons where we might consider an invasive monitoring strategy. There's a number of different methods, and I won't belabor them. I'm going to focus on the ones that are more chronic in nature, the ones that we tend to more often use in children. Well, here's that example. Here's that patient with the MEG. You can see the real localization to that area. Here's the depth electrode strategy we used surrounding that lesion, but also because we weren't completely concordant in our data, we did place some electrodes in the frontal lobe just to kind of see that there wasn't indeed seizures coming from there as well. And then this was a region where we were able to very much target that area, remove that lesion and the seizure focus, and this patient is now seizure-free a couple of years after of surgery. And so that was a very straightforward case. Here's one that's not as straightforward. Here's a patient with an insular lesion. The insula is a very deep cortical structure. It's near some very important other structures. And so this is a much more complex lesion for us to be able to define. Are the seizures coming from within this lesion, front, back? If it's coming from deep, we're not going to be able to do anything about it. And so this one requires a sort of a different strategy. So here's a patient with their insular lesion. We might place some depth electrodes around and surround this area for us to try to define the seizure syndrome. We might put electrodes on the surface as well. Here's those depth electrodes around that lesion. Here's then the surface electrodes that we put on top of that in order for us to not only define in what might be his dominant temporal lobe and frontal lobe the area of the seizures, but also be able to map out where those seizures are coming from. Here's just another picture of a grid on the surface of the brain. And again, with our ability to map out, in this particular case, where Wernicke's area, which is an important processing and understanding of language center, we know that Broca's area was in this location, and then the connections between the two. So now we have a map of where the seizures might be coming from, and also where we can go safely without causing, in this particular case, language issues. So what are some of our options? Well, this has grown a lot. When I first started giving these talks, hate to say about 25 years ago, we had a very limited armamentarium, and now this is more than doubled in size. And that's really because we can do these type of procedures often more minimally invasively as well as more safely in order to reduce potential morbidity. I'm not going to belabor them, just suffice it to say, I'm going to just sort of run through what we're talking about. Here's a typical temporal lobectomy where we removed an abnormal area of the brain. You can see that on the MRI scanner here. And then you can see the extent of resection in this patient. Again, very straightforward. We see a lot of these type of lesions, particularly in both adults and children. Here's an area where there was very abnormal brain. This is what's called a schizocephaly, so an actual schism or a cleft within the brain. Here's that SysCom image, so you can see where we think we were mapping out where the seizures were coming from. Here's that exposure of that schism within the brain, that crevice, that area, and then you can see the electrodes around the surface. We then take those electrodes. We can now see on EEG directly from those electrodes the abnormalities in these particular patients. You can see normal brain waves, abnormal brain waves. And again, we can map those to these particular areas and these particular electrodes. Here again, you can see very abnormal electrical activity and where those mapped out. And this indeed maps out to where our SPECT study would indicate to us. Other types of techniques include, you may have heard about cerebral hemispherectomies. When I started doing these way back in the 1980s, we tended to do a complete removal of the hemisphere. There have been a number of modifications over the years that have really reduced this down to a more minimal approach. And the evolution in this approach and more minimally invasive approach is really because we wanted to lessen the complications, reduce the blood loss, reduce the incidence of hydrocephalus. And as a result, now we can do these in younger and younger patients. I can now do cerebral hemispherotomy relatively safely, even in a child 3 or 4 months of age. And so, again, for the right indications, the earlier the better for these patients. With regards to disconnective procedures, this is basically a cerebral hemispherotomy as it's done now. There's a small resection just here. Actually, I don't do this resection anymore. I just make a small incision right above the blood vessels here, get down and really disconnect these parts of the brain so that this abnormal hemisphere is no longer causing interference with the rest of the body and the rest of the brain. You may have heard of a corpus callosotomy. This is the corpus callosum here as indicated. This is our view through a much more minimally invasive approach. Here is it under the microscope. This is the normal corpus callosum, and then after its division, this is for patients who have atonic seizures or have a complex seizure syndrome inclusive of atonic seizures called Lennox-Gastaut. But overall, with regards to our seizure surgery, when it comes to resective surgery, about 80 to 90% will be either seizure-free or have only rare non-debilitating seizures. So those outcomes are really quite good when one looks at the total of what's potential for these patients. The reality is that surgery is much safer than having continued intractable seizures, and that's why in this day and age we know that I've not had any patients pass away from seizure surgery, so mortality is less than continued intractable seizures, and we know that the morbidity is less because of the long-term problems that occur with recalcitrant and intractable epilepsy. So having said that, unfortunately not all patients can be cured, and so we have gone to a more minimally invasive approach for certain patients. Again, we try to target small lesions, so in something like laser ablation, ideally we can cure those patients if the lesion is relatively small or relatively targeted so that we can treat these patients well. The danger of a more minimally invasive approach is especially with cortical dysplasias. If there's a broad area of abnormality, it's unlikely that a laser ablation will cure that dysplasia. So we have to recognize that epilepsy is a network disorder. And so while we may be able to get the primary seizure focus, the origin of those seizures, not all of the patients will fall into a category of, easily treatable. And so, but this has been a great technology that we've used over the last 5 years. We've treated over 100 patients now, being able to target either tumors or tubers in cases of tuberous sclerosis or cortical dysplasias. So here's just a typical laser probe being placed. It's using our image guidance so we know where the lesion is, we know where the network is. We've now mapped that out, and we can then place this laser probe right down to the area that we want to ablate. This was an excellent treatment for patients with hypothalamic hamartomas, but now we're using it for much broader indications. Here's an example. This was a 14-year-old young girl from Hawaii that we treated about a year or so ago. She's had seizures since 6 months of age, so she's gone over 13 years of having intractable seizures. She was otherwise neurologically normal with normal development, but she was having 6 seizures per day. And these were obviously impacting on her schooling and her social component, you know, teenage girl. She was tried on multiple medications with no impact, but then came to us, and this is kind of where the evaluation came. You can see where her lesion is. It's a well-circumscribed hamartoma in those areas. With imaging, we were able to identify where her mammillary bodies are, these 2 little peanuts right down here in areas right near the lesion. Those two mammillary bodies are part of her memory function, so we need to try to figure out a strategy to avoid those and to not damage those mammillary bodies. Here's just looking at her from the side. You can see the hamartoma here, and then in this case, the mammillary bodies were coming from behind and down, and low down here being the area that we need to think about avoiding if we're going to try to treat this. We did the resting state functional MRI, and so this showed us the network, so how the pathway of her particular seizures were arising. And so you can see here that they were coming from connected to the back part of the hypothalamic hamartoma and were spreading in a posterior way. And so when we went ahead and started to consider targeting this, you can see here's the laser probe within the hamartoma. Here are the mammillary bodies over to the side. And you can see how we've placed the laser probe more in a posterior part of the hamartoma with the goal to try to ablate those connections to the network that's causing her seizures. And here you can see in this orange map that we were able to stay away from the mammillary bodies low down, but we were able to create an ablation in the area of where the seizure network was arising. And indeed, in her case, she's been seizure-free since this procedure. There are other areas that we can use a laser ablation. Here's a patient with a left mesiotemporal area of abnormality and seizure focus. And so for mesiotemporal sclerosis, this is a nice treatment option rather than an open surgery, which is what you saw I showed earlier, a temporal lobectomy. We've also used it for cortical dysplasia, and again, targeted area. This was a migration defect, and we were able to ablate this particular area in this patient. And also we can ablate multiple using multiple probes. Here we use 3 probes to be able to get an adequate map or adequate ablation of the area of abnormality. We've also used it for tumors. This is a patient with a recurrent medulloblastoma, again, who is going to go on for other therapy, but ablations can also be done for tumor cases as well. Again, moving on to neuromodulation. Again, there are a multitude of opportunities now. For the most part, the first 3 are being used, and these are all invasive, require surgical implantation. I think in the future, we might see some new work from TMS and from possibly even transplantation. I'm not going to get into these at this time, but suffice it to say is that I think there's some exciting technologies for the future. With regards to VNS, we don't really consider it surgery. It's like another medicine. The epileptologist or neurologist can really change the frequency and intensity of the modulation. Unfortunately, it does require implantation, so it is a minor surgery, but it is a same-day surgery, one that takes about 45 minutes to implant, and then hopefully we can reduce the other medicines or diet or other things that are required to gain control for the medicines. As I mentioned, it's really for patients in which medications no longer work. It is a palliative procedure. It does not cure, but there are a lot of different ways that it may help. And so it is a low risk, potentially high opportune method for treating one's intractable epilepsy. This is just an overview. It has a pulse generator below the collarbone with a series of wires, electrodes around the vagus nerve. It takes only about 45 minutes of my time to do it. Patients usually go home about an hour or 2 after surgery. Here's just typical, here's the implant on the chest, here's the wires going around the vagus nerve. It really is not really changed with regards to its implantation over the last 23 years that I've been putting them in. The generators have changed. They've gotten smaller. So now we see smaller devices as well as those with very long battery life. And in fact, now, now we have even smaller generator. And again, this new system is a great way, and I've put these in children as young as 6 months of age. And so just to look at it in relative size, here's the generator, and this is what it would look like on the underneath the skin on the chest. The long-term outcome is pretty good. We usually say about 50% of patients will get a better than 50% improvement. Now, the bad thing about it is that it does work better over time. So unlike a new medicine, which tends to treat things right away, VNS, we don't consider it a failure till it really hasn't changed seizure syndrome for 1.5 to 2 years. These are just some of the potential risks. This is an older series of mine at the point where I'd put in about 700 of these. I've now put in over 1,000. These pretty much point out the different potential complications. With regards to RNS, this has been more recently FDA approved. Again, if we can localize seizures, but they're coming from a particular area of the brain that is not something that we can take out, then for that reason, it's a very good modality for treatment. It is FDA approved for adults only. So in those instances, we would only consider a child, really if there were no other options available and it was really for best treatment for them. There's a number of components, both a stimulator and the way to pick up the seizures. The unique thing about the RNS is that the electrodes are placed right in the area of the seizure network. So the device is picking up the seizures, learns which learns which electrical activity is abnormal and causing seizures, and then gives a stimulus back. So this is sort of the typical. It can either be a depth electrode or a surface electrode. Here's the pulse generator. It's actually implanted right into the skull itself. And then this way, it can give a quick closed loop response to a particular seizure activity. This is what it looks like under an X-ray. Here's the pulse generator, the different electrodes. Here's what it would look like on the skull. And you can see it's implanted, so it's not sticking up. It's implanted right into the bone itself. We know that improving our accuracy and efficiency in these cases also reduces morbidity and mortality, and that's the reason for the new robotic systems. There are a number of different surgical robots out there now for neurosurgery. The robots don't do the surgery. It still requires a surgeon, but what it does is it improves the accuracy down to sub-millimeter in many instances. This is just a typical look. We tend to use the Stealth Auto Guide. Here's just the profile of the robot. Here's just what we're looking at in order to look at accuracy, and you can see here's sub-millimeter accuracy to the target and our ability to really place the electrodes or biopsy needles or anything else that we're going to use with really great accuracy. This is just passing those electrodes through that thing. This just, just in the interest of time, I'll pass on the, I can't pass on the video because obviously I like to promote ourselves. And
tolerance of this is millimeters. We might just a millimeter too close. She would have a paralysis.
So this was an instance of a patient where we were trying to target her seizure foci and cortical dysplasia in a very unique format, and it allowed us to avoid very important areas of the brain.
As well as more superficial. And in between, though, was this child's basal ganglia, which is a major motor processing center. This was the first use in the United States for the Stealth Auto Guide, and this neurosurgical robot worked very well for us.
So we were very proud of being involved in here. And again, it's trying to advance the technology from where it was with regards to its accuracy. So in summary, as I've talked about, intractable epilepsy, we all know significantly impacts mortality, morbidity, and quality of life. We know that outcomes from surgery are better than continued failed medical therapy, but it's in selected patients, and that's really where our innovations and approach have come. Surgery, really, our goal is to interrupt or interfere with the seizure network, and so we want to try to improve normal function and development. And with our advancements in these technologies, we know that we can truly make a difference in these patients' lives and their outcomes. So also to follow up, this is that 3-month-old. We did do an open surgery for that particular case because of the size of the lesion. We did do surface electrocorticography, which was a way to look at function. She was only in the ICU for 1 day. She was in a regular room for 1 day and then went home. This is the extent of her surgery. You can see the incision right over the area of where we ended up doing the surgery. She's not had any seizures since surgery. She's now 2 years old. This was the first time she smiled. Up to this point, she had never smiled, and this was on post-op day 2. First time she had eye contact, again, because of the developmental delay and the interference in this particular case. This was really a very gratifying procedure for this young child and her family. We couldn't do it without a team, and it does require a comprehensive center to be able to accomplish this. And I truly wouldn't be anywhere without really the massive amount of help that I get from all of these different individuals to make really a great center here at Phoenix Children's Hospital. So thank you, and I'm happy to take any questions. I think with a small group, you can feel free to unmute yourself and kind of go from there. Well, I appreciate your attention. If other questions come up, you can reach me at Phoenix Children's Hospital. It's D. Adelson, DADELSON, at Phoenix Children's, all one word with an S at the end, .com. And so if other questions come up, or if there's anything that we can do for you, please let us know.